I wrote it in and then I uploaded that to my IoT. Was that okay? Or were they supposed to be all typed in?
Oh, no, whatever you guys need to do. At this point,
Okay.
we're all guinea pigs in this new COVID world, so we're getting by as best we can, right?
Okay, I just want to make sure that if we weren't able to type it up, we were able to write it out. No,
Absolutely. I mean,
okay.
I think Dan and Lori would agree with that also.
We're good.
And how do we know if we've done it right? I mean, we've downloaded it, but nobody's graded it yet. So is this?
So they take a while to grade. As you can see with this one, you have to go through each one. So it takes a while to grade. We also have to look at your DOCUCARE. We also have to look at your Vsim. So just be patient with us. It's the first time for us too.
Is someone going to show us how to use DOCUCARE? Because I was never shown how.
Yeah, our class was never shown DOCUCARE, so I don't think any of us did DOCUCARE for Red.
Yeah. I think Dan and Laura, you guys aren't using DOCUCARE this term, is that correct?
The first termers,
I thought we did DOCUCARE, Lori.
yeah.
Okay.
Yeah.
Becky never showed us how to do it.
Okay.
To do it.
Okay, no worries.
Yep.
But we're not going to be like
Every
marked down for not knowing how to use DOCUCARE.
No.
Okay.
Or for not doing it right, because I don't think any of us did it because we didn't know how to do it.
Consider this a learning experience.
I can go over it a little bit later, and Karen can go over it a little bit later. It's really simple to find the instructions and everything, but again, knowing all this information is what's most important, because you're going to have to document all that. So we'll go over how to do that.
And with DOCUCARE, the one concept that's important to understand is when you're going through your Vsim, if you take a blood pressure, if you take a temperature, any of those things that you might want to document, you'll need to take notes and write those down, because you won't be able to get back to them once you get out of your Vsim. So just take notes. All right, are we ready to keep going? All right, again, since we're recording, so Dan only has to do one recording. You're going to need to read the monographs that the prep reading before you'll be able to fill out this concept map. Does somebody need something, or is that just background? Okay. And
A telephone story.
no worries, no worries. Oh, wow, my titles disappeared. That's interesting. Wow.
I had that happen to me in the documentation when I tried to input it, that the titles disappeared a lot.
Okay.
If you go back up and do undo up at the top, it'll take you back.
I just do a Command Z, and there it came. All right.
Same thing, yeah.
Yeah, Control Z. I hate buttons. All right. So for the diagnostic tests and reasons, you need to actually fill out the reason for the test and the results, so that if someone were looking at this, they would know that you knew what they were talking about. Patient information, their name, their age, their gender, their condition, their vital signs, their comorbidities. So it really wants the patient information here. Anticipated physical findings. When you kind of know what you're looking at because you've done the Vsim, and when you come in and someone's delirious and you see that there's sepsis going on, what will you see? What do you think you're going to see? Now that you've read all about sepsis, now that you understand, what are you looking for, and what do you think you're going to find?
A fever?
You might find a fever. You might find, well, you know, this
UTI.
is, say again, Teresa.
I said a UTI.
Oh, Maisha, okay. Could find a UTI. Red doesn't have a UTI, but you could have found a UTI. And he's got, we can see that he's limping. He has a dirty bandage on his foot. His foot is red, so might anticipate that inflammation.
Confusion.
Hey, Karen.
Yeah.
So Sorry. Did you say anything about how confusion can work with infection? Like, I know UTI is an infection, but how does it make a person confused, I guess?
So what's happening, and again, once you read about sepsis and things like that, what's happening is infection, especially in elder adults, just tends to cause more delirium. I haven't read about the pathophysiology on that, Taryn, but I know as the bacteria spreads, it affects how all of the organs work, and the brain isn't immune to that infection. So
Can I
as far-
interject?
yeah, absolutely.
The toxins from the infection affect the brain, and it affects your whole metabolism. So your electrolytes and everything's out of whack as far as out into the tissue. So when it gets up to the brain, it causes the confusion from the electrolyte imbalance and everything else out into the tissue, as well as the toxins. The toxins are the main thing, though.
But
that
your
cause
electrolyte,
the problem.
yeah, your electrolyte imbalance really answers that question, doesn't it, Dan? Because we know with a sodium imbalance or with a potassium imbalance, we know with a calcium imbalance, so we can have different things happen physically. So
You're looking at an organism that's taking some of what your body normally uses to build itself, and it's building its own nasty little bug many, many times over.
Okay.
and sepsis can go really, really fast in especially a younger, like a baby and a child, and an older adult. A middle between those two ages is we're able to fight it a little bit better if we have good nutrition. But Red doesn't have any nutrition here. He's drinking, not feeding himself. He maybe needs some help.
Another issue with Red is he's dehydrated.
Uh-huh.
And so that messes up his electrolyte balance as well. So that causes issues up in the brain as well.
Absolutely.
Part of the confusion.
I have a question. So what all would be appropriate to put in the anticipated physical findings?
Well, with him, you know that he's got the foot wound. So
Right.
what would you anticipate finding there? Would it be red? Would it be warm? And a lot of this stuff you already know. He's limping in, he's delirious. And so you have to, it's kind of weird because you feel like, oh, I should do this before I know what's going on, but you already know what's going on. So I would go ahead and put in the things that you know, you understand. Oh, if he's coming in sepsis, he has a foot wound. I'm going to look at that foot wound. I'm going to see this.
Okay.
Does that make sense, Selma?
Yes.
Okay. I'm going to see inflammation. I'm going to see some ooey gooeys. You know, you wouldn't write ooey gooeys, but you know, you could on my paper because I think that was great. But you expect to see pus. What else might you see if this wound has not been attended to? What might you see as far as tissue goes?
Tissue breakdown.
Necrosis?
Tissue breakdown, Maisha. Taryn, what were you saying?
Necrosis?
Necrosis. You could see some maybe gangrene setting in. Some
Gangrene?
necrosis. Yeah, absolutely.
Because necrosis comes after gangrene, right? Like you have that initial infection, or is that the other way around?
Necrosis is just dead tissue, and gangrene is an infection.
Yeah,
Right.
so
So you can have
necrosis.
both at the same time.
Okay.
Thank you, everyone. Thank you. All right. Anticipated nursing interventions. So you know you're going to do a head to toe on this. And a lot of people thought head to toe meant I need to do cardiac, I need to do respiratory, I need to do. And when we say head to toe, we usually are talking about an admit, and we're going to do every assessment on them. But in this particular arena, what they're saying, it's head to toe is an integumentary inspection. And that's why she said, I did a head to toe. I found Red's foot was warm and red. So she didn't find anything else. She just found an integument issue on his foot. You would anticipate absolutely doing those dressing changes, giving the vitals. You would give medications. Correct me if I'm wrong here, Dan, Lori, and everybody else. Will you assess other areas? Would you educate the family? So I know Lori's an expert on nursing interventions. What's your take on this one,
I
Lori?
am not an expert on nursing intervention.
He called me an expert on the form. I can call you.
Oh. So one thing I did find with this, doing these scenarios, they are kind of picky about what order you do things in. So do try to think what order would be best to do them in. When you go in and look at your results, you will need to kind of write down they want you to do them in before you do it again, and then, you know, restudy do your remediation pieces, and then go back and try the scenario again, just as an FYI.
Yeah, and your interventions you'll do the most emergent first, right? If somebody comes in, or if you have a resident who's passed out on the floor and you go, oh man, they've got a dirty brief. I need to change that brief first. Is that really your first intervention? Anyone? Anyone?
Well, notice the
Hopefully
difference.
not.
Sorry, what was the question? Sorry.
Aaron, late to the party. I was just saying, when you go in, you want to do your most emergent order first. If you had a patient that fell on the floor and passed out, but you noticed they had a dirty brief, would their dirty brief be your first area of attention?
No, you want to check ABCs, man.
Right? CAB, no ABCs anymore. CAB, baby.
It's CAB now? Well,
Yeah.
is it because they fell and they're unconscious?
No, it's now CAB. It's no longer ABCs.
What? Since when?
BLS. You've got your BLS.
CAB
Yeah,
and
but I got
BLS,
like
but if they're awake and oriented, it's ABC.
Okay, so if they're unconscious, then it's CAB, but if they're alert
Yeah.
and oriented, then it's ABC. I
Right.
need to write that
Okay.
down somewhere.
Yeah, anyway. So notice the difference between intervention and assessment. An assessment isn't an intervention.
An assessment
Interventions are things that you're actually going to do to the patient.
So assessment is not an intervention. That's what you just said.
Right. That's not an intervention.
Okay.
You can, monitoring is an intervention. Things like that. What are you going to do? But assessment, doing a head-to-toe assessment is not an intervention. Changing the dressing is, putting in a Foley catheter, putting down an NG tube, things like that are interventions. Raising the head of the bed, that sort of thing. Actual physical things that you're going to actually do.
Okay. Okay. Thank you for that clarification. See, I told you guys, good clarifications. All right.
That's why we have all four of us on. Go on, Deb. Jump in there.
There we go. So this one is pretty easy. An S-bar is used usually to communicate with a physician, and the physician wants to know who you are, what your position is, of course, where you're calling him from. He wants to know what the patient's name and age and his gender, his or her gender, and then the reason that they're there, specific reason for the visit is going to be important because he doesn't know this patient from Adam. They're coming in this way. If you have any, of course, if it's a different SBAR and you have any trends that are developed, you have to have 3 points to have a trend. So their blood pressure is way high. Well, what has it been before? So are they trending up or is this normal for them? He'll also want to know those kinds of things. Background. So that's what we're talking about. The comorbidities, what's happened before is in this one. We should know that the physician should know that he is septic. We've done those tests, right? Oxygen that we've given him, saline. So this is the current orders for the patient. So if we're going to talk to another physician, he needs to know who he is, what's going on, what's happened so far. Any comments there, Dan and Lori? Okay. Assessment-wise, current pertinent assessment data using head-to-toe approach.
I have a question, Karen.
Absolutely.
So it says current orders for the patient. So if you've already completed an order, is it still considered current?
It is in this particular arena.
If you try to do something that the scenario tells you has already been done, it will dock you points.
Okay, thank you.
Pertinent assessment using the head-to-toe approach. So foot dressing was, this one, someone documented that it was soiled, but they didn't document about the foot itself. So we want definitely to document that particular physical finding. Just use, I know common sense isn't common, but use rational thought. Once you write it down, take a few minutes, go away from it, come back to it, and ask yourself, does it meet this criteria? And let's see, pertinent diagnostics. So you had what kind of diagnostic tests for red?
You did blood labs?
You had a blood culture, right? Are you going to know you shouldn't know the results of that because it takes 3 days, but what else did you do?
Complete blood count and a chemistry panel.
So was that a BMP or a?
I don't remember. And a
Okay.
urine. Didn't we check a urine?
Did they do a UA? Okay. With delirium, would you do a UA?
Yes.
Absolutely. Absolutely. All right. And then your recommendations. What about this patient? Has he received the kind of care and support that he needs? What kind of care has he been receiving?
Inadequate.
One thing that I consistently see on these are people aren't treating as pain. That wound is very painful and nobody's assessing or treating the pain. So just an interjection there.
That's a great interjection, Dan.
For red,
He said his pain was only a 3 of 10.
Yeah.
and
Oh.
when I asked him if he wanted anything for the pain, he said no.
Yeah.
Well, and we don't have any orders. There's nothing for the pain in the orders.
Is there anything we can do without? There's things that we can do without having an order. Distraction. There's lots of different pain pain things that we can interventions that we can use for pain that don't need a doctor's order.
But you can't choose it anywhere.
You can't choose it on the scenario, but
On
you
the
could write it in
scenario.
on your paperwork if you want to.
Yeah, this is the documentation part that we're filling out. You can't do it on the scenario, but you can put it in your,
And don't put that you're an LPN because you aren't, you're an SP. just so that, So we would, at this point, we would recommend, I think we recommended in there that he go to ICU. Is that correct?
yeah,
Yes.
transfer to ICU.
Yeah, transfer to ICU. And then when someone is admitted, the first thing you want to think about is discharge, right? So you would think about recommending maybe senior services to help him or to find maybe a better place for him to live, maybe Meals on Wheels. Maybe he needs more than once a week dressing changes. But again, it doesn't sound like he is living in an appropriate place for what he needs.
He also has home health too.
Go ahead, Gabrielle.
I think he also had home health 2 times a week, so maybe
Yeah, he
like
did.
yeah, upping that or something.
Yeah. If he had had home health 2 times a week, that was the nurse changing the dressing, right?
Yeah.
Yeah.
Yeah, I thought it was only once, but that's fine. But obviously it's inadequate, right?
Needs more attention.
Dan, Olga's trying to get back into the Zoom meeting. If you would please let her back in.
Oh, I tried, but let me see if I can do it again. She should be in.
You got me. Thank you.
Okay.
So any questions on this particular area of the recommendation? And really, if you have questions and you're afraid to ask them or you're embarrassed to ask them, I want you to understand if you have a question, there are many other people with the same question that they're too embarrassed.
How does someone get on palliative care? I know that helped. We had that in our other facility, but it was kind of like associated with hospice. So
kind of the other end of hospice.
Yeah.
Okay.
All right.
Physical.
Yeah.
It's a physician's order. It's an order set that the physicians write out.
All right, the drug sheet. So I believe the first drug sheet is included in the time that's included for the entire packet already, but each additional drug sheet is worth another 30 minutes. So I know you'll get more drugs sheets to do. Dan, why don't you talk about the drug sheet?
Me? Okay. So the medication, that's just the basically the generic name or the brand name, what you're giving. You can either put the brand name or the generic name there. Classification in this case, I can't say that right now.
Cephalosporin.
Ceftazidime. Its classification is antibiotic. The prototype would be 3rd generation cephalosporin. So if it was like, say, your medication was aspirin, the classification would be NSAIDs, non-inflammatory or
non-steroidal anti-inflammatory drugs.
Thank you.
You're welcome.
It's an NSAID. So that would be your classification, and your prototype would be salicylates. And it's just those types of things you can find in the drug book. You can look them up online. But that's what the prototype is. Safe dose or range, if you look under indications, look for the indication why you're giving that patient that information, or why you're giving that patient that medication. It'll give you a dosage range for that particular diagnosis. So think of what I tell everybody is always look at your patient. Anytime you're doing any of this, look at your patient, write down what you see. So if you're looking at your patient and they have a wound infection, you'd go to that part of the nursing book or that part of the drug book and say, okay, they're getting this for an infection of the foot. So you go to that section and see here it says serious UTI, lower respiratory tract infection, skin, gynecologic. Why is this person taking it? They have instead of copying and pasting what the book says, give us an indication of why this patient he's got an infected diabetic ulcer on his foot. It doesn't take any more than that. It's basically that simple. He's taking the medication because he has an infected wound. Down in the patient education, if you go in your drug book, again, it'll give you lots of information on what to teach the patient, any side effects, anything anything particularly to look for, like allergic reactions, things that they should, like if they're on other medications, should they take it separately, you know, an hour before or an hour after those medications? Should they take it with meals? Should they take it, you know, without anything to eat before meals?
Could you
That
scroll
sort of
back up a little bit? Thank you.
Those
So
are the types.
basically, this all comes out of a drug book. Yes, Dan?
Yes. And the patient education will give you a whole list of things to talk to the patient about.
And remember, you can download Medscape for free. That has a great drug database with all of this stuff in it.
Yeah, that's a very good resource. I used it a lot.
Yeah, I mean, Davis's drug guide is amazing, but you know, not to pay for it, Medscape is great. So any questions about this particular form? I can't see a chat, so if you're chatting at me, you're gonna have to say it out loud. All right.
It says, will this be uploaded to my IoT for reference?
So there's certain things that you get graded for and certain things you don't get graded for during the Vsim. I know the idea would probably be to do as little as possible and get the best grade as possible. If there is stuff that we didn't actually do in the Vsim but would have done differently, can we include that in here?
It's a really good question.
I would say this is the avenue that we'd expect you to do that in.
Yeah, I think that's completely appropriate myself.
Yeah.
Okay, clinical worksheet is pretty much, sorry, don't look anybody. Clinical worksheet is exactly what it says, a clinical worksheet. And why is your patient in the hospital? Answer in your own words, include history of present illness, presenting infection. I mean, what led to the hospitalization? So malnutrition, inability, changes on not checking his feet, not taking his meds. So specify here a little bit of exactly what led to it, and then health history down here related to this hospitalization would be exactly that, the comorbidities, and maybe he's been in the hospital many times for this, and so you would want to chart that. So self-care, he's lacking in self-care there.
On his little like pretend medical record for Yoder, it says that he is not, there's no precautions for him. With that kind of, fairly intense foot wound, I mean, would we want to be concerned with contact precautions with that or no?
Contact precautions are more for your protection. And when we do that, because that means there's something communicable that can be spread. At this point, we'd want to protect him with aseptic techniques and make sure that asepsis is definitely, and with gloves, with hand washing, with keeping a clean dressing, that will be sufficient for this particular scenario.
Can I interject something?
Yeah.
So unless you have a, I think first or second week we went over the transmission-based precautions. Unless you have something that's on that disease list, you wouldn't put them on precautions. But anytime you have an infection or open wound or anything, I think I said earlier that if it's wet and it's not yours, protect yourself. So that's universal precautions or standard precautions. Anytime there's a wound or anything open like that, you'd always wear gloves or whatever you need to put on to keep it from getting all over you. So that could be gloves, that could be gown, whatever it needs, but that's, they wouldn't be put on contact precautions per se, but it's just a kind of a common sense thing. If you're going to get splashed, you're going to put a gown on so you don't get it all over your clothes, type of thing. Does that make sense?
So on his lab, it says that he is positive for staph. So wouldn't that be considered? Wouldn't he have to be on precautions for that?
Not unless it's MRSA. If it's a,
Okay.
you don't have to put somebody on precautions for just general infections. It's the antibiotic resistant infections that you would put them on precautions for.
Right. We all have staph and strep on our skin all the time. It's just not a problem. That's our normal flora and fauna. It's not a problem. It's our bacteria that helps keep us healthy. But as soon as it gets inside, then it becomes a problem. So it can be we can be overwhelmed with that normal flora and fauna.
I have a question about Red's malnutrition, but also just goes for like in general. So under the information questions, I had asked him if like his provider had told him that he was malnourished, and then I got doc points for that. And then I was telling one of my nurse friends about it, and he was like, oh yeah, you should never ask anyone that. So I was just wondering, like, why is that inappropriate to ask, and what would you ask instead? Like, how would you know that they're malnourished, I guess is what I'm asking. If you're not supposed to ask that.
So that would be diagnosing.
Okay.
And you're not, because that would be practicing out of scope. And so you could ask about their diet. You could ask how's it been going as far as getting food? Have you been able to eat 3 meals a day? Are you needing help with that? So as far as that goes, but if you say the word malnutrition, then that's a diagnosis.
Okay, yeah, I was just wondering like what that was about. Thanks.
Also, if you're asking if the doctor asked about that, that's kind of throwing the doctor under the bus if he forgot. So you never ask things like that. You can ask if, have you been, has anybody talked to you? Just kind of general rather than specific to the physician. You can say, have you been educated on malnutrition? That type of thing. Make it general rather than specific to the provider.
Yeah, and I would definitely just not use diagnosis words if you don't have to. If you can put it in more plain terms for them, because it's almost like an accusation.
Yeah.
So
that's why they did that.
Yeah, and in the scenario, it's very specific what you have to do for the scenario. So yeah, it's kind of a bummer, but you'll figure it out. It'll happen just like the NCLEX. When you look at NCLEX questions, you're like, what the heck is that about? But once you find out how NCLEX asks questions, then you'll know exactly how to respond. And that's kind of what we're doing here.
Yeah.
Is learning this program.
Another approach, you could ask the patient if it's okay if you have the nutritionist or the dietitians talk to them about their nutrition needs.
Right. Dan, I didn't notice, but it's I've got 12:57 there. So at 1 o'clock, we should take a 10-minute break.
Okay.
And then we'll see. We'll finish the form. Then.
Hey, Karen.
Yeah.
Hey, Karen. Someone's asking about go over the remediation. Tell us how to do it, because most of us don't know how to do it.
The remediation?
Yeah.
It basically,
go over that after this.
Okay. Yeah, it's basically just 12 check boxes.
Okay.
And filling in filling in that first column. What did you do wrong?
It gives you all the answers, so you just basically underline, circle, check.
I have a question in regards to that. So we got, or in the week 8 timesheet, it says that anytime there's like 2 red X's or 3 red X's, we need to remediate that section. So if you have like 4 or 5 sections of that, that would be 4 or 5 remediation sheets for that. one.
We'll
Is
go
that
over the
correct?
remediation form after this. I can go over it pretty quick with you.
Okay.
It's really simple.
It's sweet. Okay.
Doesn't have to go into a lot of detail.
All
So
right.
do we want to take 10 and come back at
Yes.
All right. I'll see you guys in 10.
All right.
You can pause your recording, Dan.
record. Am I on?
Your name is on.
No, the other thing.
You're recording right now, so go ahead and share again and ask that question.
Well, if I knew where that was, I would.
The green button, share.
Yeah, but it was covered up with another button. I'm
The
not
other
sure what to
button.
call it. I have lots of names I could call it, but it wouldn't be appropriate.
There you go.
So in the user guide,
Wait a minute. The question is, where would you find resources to know how to fill out the clinical replacement packet? And the answer is in student instructions, student user guide in the Vsim student resources.
right?
Page 11 for that particular part. You're so well. You're welcome. Thank you, Dan.
I need to interject that I have one student on the list. It just says iPhone. Could you identify yourself?
Yeah, sorry. My name is Daisy.
Oh, thanks, Daisy.
And you guys could check in again on the chat, and we can always look at the chat later to make sure.
Yeah, be sure and your name's in on the chat.
Under the 1 o'clock hour. All right. Do you want to finish?
Do for 1 o'clock too?
13. Every time you check in after an hour, you check in with your name so we can take attendance each hour.
9.
Makes
Oh,
it easy
so-
for me. And
Did we lose a lot of people?
Were we supposed to check in 9, 10, and 11?
But I think Lori and Deb both got roll, so I think you're okay for that first 9, 10, 11. Or 9 o'clock and then 10 o'clock, because I think we ended at around 11. Was that
So,
Tiffany?
I'm gonna stop sharing so you can share.
Aw, we all like to share. It was Tiffany, wasn't it?
Yes.
Yes. I'm starting to recognize faces and voices. I get to meet you guys in person. Oh, wait, I take temps sometimes. All right. So let's go back to,
I'm gonna bring up that sheet if I can find it.
I've got it.
You got
But
it?
can we finish our other one first?
Of course.
Okay. I'm trying to remember where we are, I think.
I'm trying to get back to where you are.
Yeah, I've got the sheet open. I'll share that in a second. So
Awesome.
Here we are. Why we're in the hospital. Okay, we already did that one, right? Or no, this was what we were on. The clinical worksheet. So health
Shift
history we
goals.
talked about. Shift goals. Thanks, Maisha. So I think these are good shift goals. You want to control infection with, how would you do that? I would maybe specify here a little bit more. How would you do that? I mean, I don't know if I would use the words control, but infection, right?
Proper dressing, I don't know, wound care. We be more specific than that.
That stands for antibiotics.
Oh, there you go.
Yeah. So antibiotics, wound care. What else? We might need to feed the man.
Yeah, I put that into, and I also put in maintain glucose levels, and check intake and output.
Yeah, because there's an order to insert fully if he doesn't void in 6 hours.
Oh. I'm not writing very well. Let's see, exercise and I want to say serve him some food, but that's not what I should put here.
Meal plan.
and well, what are the words? Well, get him some food and
serve food at mealtime.
Establish a diet plan.
Establish diet plan. And I want to feed him though.
I put ensure complex carbohydrate dietary orders.
Oh, good.
Yeah.
Okay. So anyway, hey again.
You're saying some adequate protein.
Okay. Yeah. Ensure. Maybe we should just give him ensure. Okay. No. Okay. Sure. Nutrition levels met. There we go. It sounds more nursey. Maybe, I don't know. Oxygen to appropriate level. So that would be maintaining what? Maintain
Proper oxygenation.
Yeah, proper oxygenation. So that's she said it fine. We're just going to leave that there. Okay. Delirium reversed. I'm not sure I agree with that, even though I put great job here. Is the delirium, I mean, it's a great goal though. It is a good goal. We always make impossible goals sometimes, don't we, with nursing?
But sometimes that might be a long-term goal versus a short-term.
Right.
Within a shift.
Yeah. Or maybe protect patient from fall, right? Establish, maybe that's what we want to do here is maybe make sure that his fall risk needs are met. I know we're going to transfer him to ICU, so I'm pretty sure they'll take care of it, but that's still your shift goal is safety due to his fall risk.
Do we need to go in detail about that too? Like things that we would do, like, I don't know, use a cane if needed, or I don't know, something like that?
I'm sure there's no reason. What you're doing here is developing your nursing care plan, really. Is what are you going to do for him? So patient education needs. Are we going to be able to educate Red?
Not too much.
Not too much, but does he have somebody really concerned with him?
It's a daughter-in-law.
Yeah, she's pretty concerned. So maybe this patient education needs to be family member education.
Well, and because the wound is so severe, wouldn't you want to, as a short-term shift goal, wouldn't you want to maintain like a pain level, like a lower pain level?
His pain is at 3.
Yeah, but wouldn't you want to keep it at a 3 so later on?
Right, maintain. Yeah, that's a great thought, Karen. Yeah, maintain adequate pain.
Adequate comfort.
Maintain adequate comfort. Don't maintain his pain. Maintain his comfort. Yeah.
When you're thinking of shift goals, think of Maslow's hierarchy of needs. What's most important on the bottom level? What's the most important thing?
Physiologic.
Say it louder.
Physiological needs.
Safety.
Safety.
So fall precautions with the delirium patient would be pretty high on the priority.
Like bed alarms and stuff.
Bed alarms, all the things that you would do for precaution, but you just have to put on their fall precautions.
I was going to say, could you do like fall risk eliminated? Just because like with all the fall risk prevention you could do, like your goal just to be prevent any type of fall risk.
Yeah, that's comes under fall precautions.
Okay.
Yeah.
Maintain fall precautions.
Yeah. And that's, you have a whole list of things in your facility that you would do with the patient. You know, keep the bed in a low position, make sure they're supervised when they get up and walk, that sort of thing. There's a whole list of them.
You could be specific to fall risk precautions according to fall risk scale, patient rating, something like that, if you want to be a little more specific about what would be the right category for him or something.
Right.
And I think this form is a great form to do with another student, to just talk to each other, just like we're doing today, to work through these things, because it's a learning form, and this is all about learning. And a lot of you have different experience, so you have different understandings, and I think you should share it.
Hey, Karen, I had a quick question.
Yeah.
So when you guys grade our the one that we've already done, you're gonna type in your notes and stuff like this so that we can see how we did, how we could do better. Where will we go to find this graded
it'll be
packet?
Graded and returned to your My IoT.
No.
Okay.
It's on. Oh shoot, we're not doing it on.
This is the clinical replacement packet, so they download it.
Oh crap!
So it's okay. It's all really confusing right now to everyone. So
Dan, didn't you say you were not grading? I thought you had said that we were not getting graded on those. Is
we're
that
not
still right, or am I just imagining that?
We're not giving a grade per se, but we are going to go in and give you feedback.
Okay.
It'd probably just be easier to email it, wouldn't it be?
No.
Either way, but I think if we just download it back to My IoT, then everybody will know where it is.
Yeah, Bonnie wants everything downloaded to My IoT.
There we go.
And if we get too much stuff on our email system, it shuts us out.
And that happens really quick. I've got over 200 emails that I haven't even addressed yet, just between the last 3 days.
Yeah.
Hey, Karen, in reference to, you said talking to your friends about this packet, you can also talk to your duck.
That's right.
Oh, yeah.
Right. Absolutely. Because the duck is has so much that's been input, it can give back.
Can I play my duck song, Karen?
Oh, I don't know, Dan. Is it appropriate?
Yeah, we have asked that question.
You've heard that one, haven't you, Lori?
Oh, probably, but I don't remember it.
The duck that Sean played the music on?
No, you can't play that one.
That's definitely not.
We are recording.
If you don't leave me alone, you're gonna have to send me home.
Okay.
That's my duck. I like my duck.
That's right. Everybody should have a duck. I've thrown ducks at everyone. So as far as shift goals, as we've heard from you guys and from Dan and from Lori and everyone, there are many things that you could put here. You don't need to write a book, but you need to maybe put what you think is most important.
Bullet points.
Bullet points. That's right. Well, maybe
this is like what you're going to put on the. This is like what you're going to put on the whiteboard if you're in the hospital. Patient goals for the day. These are the types of things you're going to put on the board. Like for a patient that needs to be ambulated every 4 hours, you'd have that on there.
Okay.
So that's the kind of things that you're going to put on here.
Okay. That's
everything that we've done is appropriate.
Okay. Path to discharge, infection control, normal vitals. So we won't want to put normal in anything. That's not a word we want to use. Lower glucose levels, or how about appropriate glucose levels? So getting him in good shape before we send him home. Path to death or injury, untreated wound. Sepsis kills quickly. So untreated sepsis. There's a few things that you can put there, but it's really good. I think it's funny. Someone thought, well, what if I just put car crash? it would needs to be appropriate to the case. You know, small grenade. You know, it needs to be related to the case. Alerts. All right. So if everybody, again, instructors want to chime in on this, delirium is a big sign or symptom, right? This is a big alert. This is a big red flag for everyone. And not that he needs to be on a lockdown unit, but he does need to have all the risks attended to. And a delirium is a big one. He seems to be, Dan and Lori, we're talking, he seems to be appropriate in his behavior. He's just confused. So he's not a danger to anyone else.
The question you need to ask when you see that is this a new onset?
Okay. Yeah. That's a good way to put it. I like that. Sepsis. What are the signs and symptoms of sepsis? Does anyone know? Okay. Usually that's part of it.
Fever,
Yep.
patient being lethargic, would that
Could be, absolutely. Because, you know, that's leading to death there, right?
Which one are you on, Karen?
I would imagine a decrease in urine output.
The alert sepsis, just the symptoms and signs that
it's
they might
increased white
see
blood
from
cell count, too.
sepsis. Absolutely, yeah.
Well, with the white blood cell count, wouldn't you see an elevated in a lot of different tests too, including
The
with the white blood cell
lactate,
count?
he did have a lactate done, did he not? Okay.
Yeah.
Are you
Because
on the assessments here?
Acid dot. Just talking about what are you on alert for with this patient? Signs and symptoms. So we're talking about the signs and symptoms of sepsis.
Okay.
Are you not able to see it?
I do now. I was.
Okay, good.
My computer is not cooperating with me.
Uh-oh. I'm glad we're still on Zoom though. Okay,
I think we're still recording even.
That's good. I can't tell from this end. Oh, there it is. There's a little blinking red dot. Okay. All right. So we've got some good signs and symptoms for sepsis. So the other things that you would be on alert for with this patient. Anybody think of anything else?
Falls.
Mm-hmm.
Oxygen level.
O2, right? Because you want to titrate that oxygen to keep him above what? Okay.
Well, so the simulation said you wanted to keep him above 94.
Yeah.
Wouldn't you be on an alert for his blood glucose level as well to be aware of, since he hadn't eaten, you wouldn't give it, but on that sliding scale, if it doesn't decrease after he eats, then you would need to give the insulin recommended by the doctor's orders?
Absolutely, be on alert for, because he's got an infection, it may shoot up. Also because he's dehydrated, there's a lot of things that can go on with that blood glucose level. So absolutely.
Don't you also have to be aware of the infection worsening?
Right. Different signs of, and at this point, because he's septic, when people go septic, some of the things that you might see is a decrease. You have other organs that are affected by this. His heart may be affected, his lungs may be affected, his kidneys may be affected. So, and obviously he's acidotic now, his respiration rate is increased, his lactate. So we know that he's having problems and that infection is spreading.
You also now have a patient who's got an IV in and he's getting IV medications.
Oh, yeah. What would you be alert for on there?
Make sure he doesn't have that same IV for over 72 hours.
Okay.
And infiltration.
Okay. What else?
Irritation at the IV site.
Right. And what else about the medications you're giving him?
Side effects or adverse reactions.
Absolutely. Good job. All of those questions should be answered for the viewers. All right. What assessments will you focus on for this patient? So basically, how are you going to identify the above signs or symptoms? So every one of those that you mentioned, you'll be assessing. Can you assess from the doorway?
Hopefully.
Absolutely, you can. As soon as you walk in the room, you're looking at that patient. Is he breathing faster? Is he sweating? Does he look feverish? Is his foot, you know, if you've got your is that redness creeping up his leg? There's a lot of things that you can just look at someone and see. So you would, as far as your glucose monitoring, that would be that. And this is an incorrect statement, so I'm going to take that away. Because you're really talking about this here.
Yeah, these are the actual assessments. What assessments would you look for? Or what assessments would you do? Skin assessment? Fall assessment?
Wound care assessment.
Wound assessment for sure.
Wound assessment, yeah. Those are all the assessments that you're going to do to watch for the other things above.
Uh-oh, someone's crashing. Wound assessment.
Neuro assessment. Wow. Cam assessment.
Yeah, your cam again, maybe.
Yeah, cam or delirium, yeah. Fall. I don't think it's going to let, oh yeah.
Wouldn't you do a neuro assessment as well?
That's
I don't know about neuro.
No, it's more the CAM assessment. It's the mental health rather than the actual neurological.
So neurological is going to be their sensations.
Yeah.
Would vital signs be you would list under there because you'd still need to measure the respiratory rate, the heart rate, the O2 sat, that type of stuff that would all show up with your vital signs?
Nice. Yeah, they sure would.
So when you're doing this, you see 1, 2, 3 there. So prioritize. What would you do first? What would you do second?
I like that. Yeah, especially on your form. Treat this like we talked about before. What are you going to do in the Vsim? You're going to do the emergent things first.
Yeah, look at your patient and say, okay, this is what I'm going to do first. This is what I'm going to do second. This is what I can do third. What's most important to that patient to get them discharged? Sorry.
No, that's great.
I
Okay.
had a thought. It
Those
just came out.
Those are good when they come. All right. Any questions about these particular areas that we've gone through? So any complications, adverse reactions to medication, allergies, that would be under medication also, proper procedures. Anyway, I'm not sure what that's about, but what would you, related to this diagnosis, procedure, or comorbidities, what complications do you see that could happen?
Shock?
I did pressure sores.
Yeah, yeah. UTI because he's been dehydrated.
I have a question. How would allergies be a complication? Because in the beginning, didn't it say that he had no known allergies?
Right. Well, he's also getting a medication, so we don't know if he's allergic to it.
Okay.
And these two, I don't believe this is someone else's packet, and I don't believe these are great ones. That's why I was just asking you guys what other ones.
Yeah, that's the first. That's number one. It deals with allergies and adverse reaction to the medication.
Could have put potential allergic reaction to new medications or something like that.
Yeah.
So I'm not saying the answers on this at all are right. This is someone's, and I've got comments on it, and I got the permission to use it. I guess I should have that beginning.
So what's going to happen if we don't treat his infection? He's going to go into shock, right? Is that a complication?
It might be napping.
I would hope that everybody would say that. He's going to die if you don't get that infection treated.
Right. What happens if somebody doesn't notice the bed alarm because they're too busy to go to that ding 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 ding?
Fall precautions.
And wouldn't you want to do oh my gosh, wouldn't you want to do blood cultures to make sure that, because I think that's what I put blood cultures to make sure that you're giving the right antibiotic.
So like a trough level, but ceftazidime doesn't have a trough level. But blood culture did have.
Oh, the culture. They did one culture and sensitivity on ADMET.
Oh, because that was a Staph aureus. Never mind.
Yeah, that's why they ordered the ceftazidime, because that fit into the category that would treat that infection.
The cephalosporins or whatever it was.
Yes.
Yeah.
Cephalosporins. Yeah.
Ceftazidime or one of those.
Cephalosporins.
Yeah.
Yeah. All right. What nursing, medical, nursing or medical. So here now it gives you, and these are not, again, these are not answers that I would have preferred, but again, this is their first time. I think great job just filling them out. So what nursing or medical interventions may prevent the above alert. So here you can see what might happen if things didn't go right. And here it is how you would prevent those.
So keywords on the NCLEX, you're going to look for keywords and questions. Interventions, things that you're actually going to do. This doesn't have anything to do with anything that we're going to do. So look at the word intervention. What are we going to do to intervene or prevent the complications that you listed above? These all should tie together. You look at your patient and they all should tie together. Back to you, Karen.
Well, you'd still want to take would you want to take continuous vitals on them, or?
Well, what's most important?
Routine wound care.
Routine wound care.
Wound care is probably important.
Putting a nasal
Infection control.
monitor.
First, you want to put fluids in because he is septic, so you're always going to do that. So we prevent that.
Fluid resuscitation.
Yeah, fluid resuscitation. I like that. That's Deb. She's very quiet. So that we prevent that blood pressure from tanking if he does go.
If you're doing that, then you definitely want to monitor his eyes and nose.
You definitely
It's
would.
good you're working.
Yeah.
Especially when he's dehydrated.
Yeah. And antibiotics, that's going to prevent sepsis. I should have put septic shock, but antibiotics to prevent more increased infection.
Yeah.
You could also reposition him so he doesn't develop new ulcers, and then so the ulcer that's on his foot isn't pushing on anything else.
Right. 2-hour turns.
Here's
the president's calling, Dan.
That's fine. I'm going to mute that if I can.
Just push the side button. All right.
when the boss is calling, it tells me your boss is trying to reach you on your cellular device.
Oh, that's right.
I know when it's Bonnie.
Okay, so medical intervention. So yes, you would do, again, go from most important to least important, but list those. Does everybody get those? Are we good?
Yeah.
Okay.
Awesome.
management of care, what needs to be done for this patient today. This is, I have to say, this is all going around the same subjects. What it's trying to do is get you to focus on what is most important. And like Dan said, what are you going to do to intervene? Intervene as a nurse. Nurse's job is to treat the effects of disease or medication. So you are going to give those nursing interventions to treat the effects of what's going on. But what does need to be done for this patient today?
Give fluids.
Fluids, give fluids, right.
What I would encourage with all of this is to at least have a little more full sentences, more explanations, and keep in mind that all interventions need to have a goal and a reason. So how often are you going to do it? How frequently are you going to do it? When are you going to check back on it?
So would you say something like CBG's Q4, and then like to say if he's like NPO, and then wouldn't you want to like administer pain meds, check with patient in an hour or something like that, like for charting purposes? Is that what you're talking about, Lori?
Yeah, pretty much. Like with medications, obviously there's a specific time frame that things can be given. So, you know, as far as pain medications as ordered or as needed per orders or something like that. But if you're talking about doing dressings, you know, are they doing the dressings twice a day, 3 times a day, once a day, every other day? And what is the expectation on that? Are you expecting it to be better in 2 days, 3 days? So think about not just what you're going to do, how often are you going to do it, why are you doing it, and when are you going to check back on it?
Well, and I've seen a lot when we change wound dressings at work, a lot of the nurses, they like to initial and put time of date on when they changed it.
Yes.
Because you can't always, unfortunately, rely on nurse charting. So, unfortunately, but you would say it's 100% of the time you'd be able to rely on it, but that's not always the case.
Yeah, nobody understands the role of a nurse, even a nurse. Oh. Okay, good job there. And then priorities. So basically you're taking these things and giving it a 1, 2, 3, 4 priority. Just like Dan was saying, Maslow's most emergent. You just want to make sure that the things that you listed, that you've got your priorities straight.
Number one priority is safety. So fall prevention would be number 1.
Oh, interesting. Okay. Yeah.
And then the physiological needs of sepsis and that sort of thing fall in. Oxygen, you know, monitor oxygen, that would probably be number 2. Infection control 3. Diabetes management would be further down, but think of that. I was going to say something and I forgot what I was going to say. I remember. Remember what Karen said earlier. When you do these, get in a group, do collaboration, talk to each other about what to put down here. You know, decide on what you want to put down, what's most important, that sort of thing. Talk to each other. That's what we nurses do. If we have an idea, if we were wondering how to set up a care plan, we'll talk to somebody and say, hey, can you look at this and see if I got everything I need on here? It's always good to have a second pair of eyes when you're doing something like this, to just make sure you covered everything, because we're not perfect. We always make mistakes. We always overlook things. So having a second pair of eyes on something like this is always important when you're out in the field.
All right.
Back to you, Karen.
Just aspects of what can be delegated, who can do it. I haven't I'd worked dialysis in a hospital, but I don't ever delegate. I was the one delegated to. So the only thing that I was thinking in my head here at this point is that he's going to go to ICU. CNAs can do the vitals and the CBGs, but other than that, you're the go-to kid. So, right?
Some hospitals have wound care nurses also, so that can be delegated.
Okay, I like that. Thank you. Wound care.
Nutrition.
IV therapy, maybe.
IV therapy, dietary.
IV therapy. Oh, all of a sudden we're yelling. Therapy.
Don't yell at me, I get my feelings hurt.
You want your voice
what did somebody say something else?
Also, in some hospitals, you have to be or in all hospitals, you have to be a CNA 2 to do CBGs. But you can be a CNA 1 to do vital signs. So that might need to be specified.
Yeah, they're starting to hire a lot of CNA 1s at the Salem Hospital right now just because, you know, we're understaffed. But they give you a whole list of stuff as CNA 1s you can do and stuff you cannot do as a CNA 2, which is the CBGs is something you cannot do, like Karen just said.
Yeah, and they pay for education. So get in there and get a job.
I thought it was funny when they say that CNA 2s can only do CBGs, because when I worked in an assisted living facility as just a caregiver, and I was able to do CBGs. A lot of the caregivers did CBGs, but when I got my CNA, I wasn't able to do those anymore. So it did throw me for a loop.
It depends on your the facility that you're in. Assisted living goes under different guidelines than a hospital does.
Yeah.
Assisted living is long-term care, and hospital is acute care, so the regulations are different there on who can do what.
I know what you're thinking about as well, but in order for us to see CBD, the nurse has delegated for us to do it. Living facility. So
at assisted living, you're not practicing on your own license though, like you are as a CNA.
Yeah.
Also, oh wait, I lost that thought. Never mind. Dan,
So
you're catching.
anything that a CNA does has to be delegated by the RN.
Oh, when
So
you
it
get
all
into
falls back onto their license.
when you get into second term, I can't tell you how many med aides or caregivers get into second term, and when we do medications and we do all these things, they come back to us and say, I can't believe that they let me do this. So it'll be a good realization that they hire somebody off the street and in 8 hours tell them that they can give medications to people that they have no idea what they're doing. 11,000 deaths a year, that was in 2000, per medication errors. 11,000 deaths in the US a year.
So just a thought there. When you give medications as a caregiver in a assisted living facility, you're working off the RN's license. It's just like she's giving the medication. So if something happens, if there's a mess up, she's the one held accountable, not you.
Yeah. Okay. This is not what I'm trying to do. I'm trying to stop that. And then I'm trying to, let's do this. Let's do it this way.
Hey, we're back to the same spot.
No, we're not. I don't know what you're thinking. I don't know what you're thinking. How about this? Does that look better?
Can I interject here again? Still?
Can I stop you? No, I'm kidding. I'm kidding. Go, Dan, go.
Do you have a mute button? It's the only way you can stop me.
No, I don't have it. You have the mute button.
Over in the first column where it says incorrect action, write down there what you didn't do appropriately.
So
assess wound, that sort of thing.
From what I understood, these are basically check boxes.
Except for the first one.
It's not big enough to write anything in.
Well, yeah, I know, but that's on our form. It's not. We need to make it bigger, but that's what needs to go there.
So you can check it here and answer it here.
No, the incorrect, you have to put the incorrect action there, what you did wrong, and then why you would do it differently here. What you would do and why you would do it differently. Does that make sense? And all the other things here are checkbox. If whatever the insufficient information or lack of knowledge or other reason, those are just check boxes.
How about that?
But you need to identify the incorrect action and then what the correct action would be and why.
So you can make that box bigger and then write in it.
Yeah.
Oh, that's not what I wanted to do.
You can write in it and it'll make it bigger.
Karen, is there any way that once you make this bigger, that you can upload it to like my IoT so then we can access the one that has the space to write the incorrect?
Oh, did you see how I did it? All I did was grab the top of here and move it. That's all I did.
Okay.
That's all I did. And so you guys can actually make them as big as you want. And if they don't text wrap, all you got to do is go up here and say, hey, not that one. Don't do that one. Right here, and then tell it to text wrap and it'll make it go into lines.
I have a question. So since I saw you were able to retry to do this, because I didn't want to do this because I didn't want to like mess it up or anything. So I retried it until I got 100%. Is that okay, or do you have to? You only get a certain amount of times that you can retry it, or
you can do it as often as you want. You say the requirement is 85%. If you did it to 100, good for you.
How many of these forms do we have to do?
What Bonnie has said is anytime you do, you get a grade less than 85%, you're supposed to remediate on every one of those. The workaround there is let it time out on you, or as you get closer to the end, exit up at the top, and it won't give you a grade. It won't give you a remediation thing.
You're telling them how to cheat. What are you doing?
No, I asked Bonnie if this was okay.
Oh, okay.
And so if you want to go through and think you've got it all together, then you go do the sim. But for every time that you actually do it, you're going to have to do a remediation for every one that you get less than 85 on.
Can you see what I'm doing? Can you see me in the Vsim?
Yes.
Okay. So what he's talking about is, well, showing my low score again.
Okay, Lori, this is where you look to see your attempts. See down here on the bottom where it says click here to see all previous attempts?
Down there. All right. Okay.
Right there where Karen's got the pointer.
Okay.
If she clicks on that, it'll open everything up.
I'm not showing everybody on my 0 attempts.
Hello, Mr. Yoder. I'm Amy.
Okay, so what he's talking about is this X right up here. So if you X up there, it's going to end the simulation. It's going to give you a 0%.
It's going to get messed up.
All right, and so I see my 0%, but I don't see today.
If you click on each one of those, it'll give you the whole list.
And so it doesn't show today because I X'd out of it, is what Dan's saying. But the problem with cheating is if you X out of it any time instead of do this, you don't get your feedback log because it doesn't record your attempt. Does that make sense?
Yeah, what I'm saying is get in there and play around with it, familiarize yourself where everything is. Look at the different tabs, find all that out, and then you go in and you do your simulation. That's when you want to get a score and find out what you didn't do right. But understand where everything is and how to play the video game, so to speak, first, and then go in and get your grade. Because I don't think it's fair to, if you don't know the rules of the video game and you don't have the rules there, you need to know how to navigate everything. And since we aren't teaching you that first term here, this is kind of a get in and find out yourself type of thing for this term. So get in and play around with it first. Click on all the buttons, click on all the areas, kind of get an idea where everything is first. And
Try to
after
break.
that, then you can go back and do the simulation. Does that make sense?
Are they still with us?
I think so.
It times out automatically after a half hour. Is that correct? It'll just shut you out and not give you a score then, or you have to X out to not get a score?
It's a good question.
To just play around.
Because when you hit the X in the top of the corner, you will not get a score.
Yeah.
Okay.
It did not time out after 30 minutes. It took over 75.
That's what I saw too. 75 minutes.
Oh, really?
Yes.
What did you say?
It takes over 75 minutes for it to time out.
I heard 5 minutes, but I didn't hear the real number.
Over 75 minutes to time out.
Yes.
70. Interesting. I wonder if they increased it.
No,
for
I thought it was probably longer than that, but I didn't time it when I was doing it the other day, but it felt like a lot longer, so.
They told us that it would time out after 30 minutes, but I think you're right.
Did you guys put it on pause?
No.
I'm gonna say I didn't. I did occasionally when I did it, but the first time, no, and it seemed to last a lot longer than 30 minutes.
If you put it on pause, that doesn't count for your 30 minutes.
Well, I asked her about that, so I'm curious now. She didn't know how long you could pause it. So now I'm curious if you have to get up, run to the bathroom. It was 75. Oh, look, it's right there. Go back.
Up here.
You have 75 minutes to complete the simulation, but you can pause the simulation, but stop doing that. That you can pause the simulation by clicking the pause button. We were told 30 minutes.
And somewhere else it says 30 minutes.
Maybe it's 30 after like inactivity, so if you don't touch anything on it.
You know what? I think that's what it is too.
That would make sense.
30 minutes of pause. You only get 30 minutes of pause. Okay. That's awesome.
And supposedly, if you let it time out on you, you don't get a score, but I don't know that for a fact. I didn't do that.
Okay.
I was trying to remember because it did time me out the other day when I was in it because I was also helping fourth termers do stuff. I do not remember.
All right. That's super cool. Okay. Are we good to go back to our form? Yes, Karen. Shrink the screen. Okay. So I did not read the text thoroughly. I can't read sideways. I'm going to have to turn my computer. I did not read the text thoroughly. The information was not in my notes. I studied the information but couldn't remember it. I knew the information but could not apply it. These are all X boxes.
Yes, quick question.
Yep.
So all we do is we like write a reason in the box on the very, very left, our action, and then we just put an X in the whichever thing applies, right?
One or more, yeah. And then Dan says incorrect. See, to me, this is a title. I'm turning it sideways.
I thought you had to write if the incorrect was like a 3 or a 2, and then
whatever it says in that.
So I saw incorrect action, if you turn it sideways, as the title of this column.
No.
Was your incorrect action, I didn't read it, or the information?
Keep going higher.
No, I'm saying, that's what I'm saying, is incorrect action. If you turn it sideways.
Column. Yeah.
So this is not, you don't do anything here. This is just the title of this.
Yes. In this space here is what you put in.
So in all of these are where you check what your incorrect action was.
No. This is why you made an incorrect action. Can you scroll up a little bit? The other way.
The other way.
My up, not your up.
So was
Why
the
did you make the mistake? Was it insufficient information? Was it lack of knowledge or navigation skills or whatever? But the incorrect action is actually what it says on your 2 or 3 dot error. It'll say you didn't assess the wound, you didn't assess sensation, you didn't attach the O2 monitor. That's your incorrect action. So
on mine, like the other reason, sometimes it was I did things in the wrong order, that they wanted it done in a different time. So
you could
have had to put incorrect order of interventions or something.
Yeah, because what I did, I made a remediation one, and I put just the incorrect action I did just in that box that's like below incorrect action, because I figured that was the place.
I do.
It's 2 o'clock. Did you want to give them attendance?
Go away, come back.
Break time.
10 minutes.
Dan, can I talk to you after everybody logs off, or one of the instructors?
Nobody will log off. So
we'll all be here. Oh, you mean
be,
after the meeting, you mean?
Like this 10-minute break, just because
you'll have to do it on a phone call.
You want to call me?
Sure.
Okay. Break time. Right?
Oh, you want to give me your number so I can call you?
503.
Okay, hold on. 503
757
757
3552.
You should have stopped recording.
3552.
I'm resuming recording.
Thank you. All right, here we go. All right, DOCUCARE portion. Let's make this bigger. So remember, you have taken down all of the things that you've done that you would need to document in the EHR or the electronic health record, correct? So if you did an assessment, whatever kind of assessment you've done, what kind of assessment would you have done on him?
A head to toe.
And what would that be listed under on these tabs?
What were your findings?
Tegument?
Yeah,
exactly.
Nice job. Okay.
Can I interject one thing before you get too far?
Always.
Up at the top. Can we go clear back up at the top?
Oh yeah.
Where it says instructions. These are your 4 things that you're going to be documenting. That's your assignment in DOCUCARE. So you're going to document your head to toe assessment, your findings there. The findings were mainly integumentary. You're going to focus on the wound assessment, and you're going to do I think that one, I can't see, it's covered up.
Document your assessment. Here, let me
You're
see.
going to do the CAM, document your CAM assessment. And so the CAM assessment goes under which assessment tab? That could be it. So that's the way to look at those questions. What is it asking? There was 3 assessments and then the patient teaching or family teaching. So your first 3 assignments are going to be under the assessment tab. And then the next one will be under the, I think it's flow, or under the patient teaching. Right here. Oh, you can't.
So one of the things that, so document your head to toe, demonstrate head to toe and focus assessment of right foot. Document your focused wound, assess patient's delirium, confusion. Okay, that didn't work out the way I'd hoped. But assess the patient's delirium. It's kind of telling you down here the same kind of thing that it's doing up here. So here your learning objectives will direct you on where to go. And this place here is a good place to start practicing your nursing notes. So if you say, let's say you put his behavior as evasive, you might want to document patient states to back that up. Patients asked patient about drug use. Patient states, I went on the merry-go-round today, you know, evasive, whatever. I can't think on my feet here. We're sitting on my behind. But up here are the clues. These are the clues of what you're going to document. So it's pretty blue and blue, not quite black and white. All right, Dan, where do you want me to go?
That was it. Just wanted to So they knew where to look for what they're supposed to be doing, what they're supposed to be documenting.
Is DocuCare like do we with ATI we had to have like a product code? Is it the same with DocuCare, or how do we like log into it or get access to it?
I'm gonna die. I'm gonna have a heart attack right here on the spot.
I know, right? So
we went over this ad nauseum in class. So anyway,
Hey, Karen.
Yeah.
We'll do that offline.
Can you scroll down? Someone asked about where do you do the wound assessment at?
Well, what you're doing, remember what we talked about earlier? We talked about demonstrate a head-to-toe focus assessment of right foot. What is that? What does a head-to-toe refer to in this particular scenario? Does it refer to every assessment you can possibly do?
Yeah.
Or does it just refer to the integument?
That's what they're thinking, yeah.
Yeah, that's what we talked about before. It just refers to the integument. So, and here it even helps you. It says only record a clean, dry, intact assessment if you've completely assessed the patient and found no lesions. Even if the skin is clean, dry, and intact, you may still want to record a Braden scale assessment depending on the patient's diagnosis and risk for, but he is not. So site wound, so you're going to reassess. Correct?
When Katie asked about like the DocuCare and stuff like that, we were literally just given a sheet with a code on it. And then when I tried to put DocuCare onto the Vsim thing, it asked for a class code. So I can't even access it.
So you were given the sheet with your code, and then you were given the class code.
Is the class code on the same sheet? Because I couldn't find it anywhere.
Can I interject?
Yep, go ahead. Don't have a heart attack.
I'm gonna have a heart attack because we went through this in class. And I asked if everybody was on. So
that was, I believe, Jan's class. I don't know if Becky's class went over it.
Let me
Becky's
finish.
class didn't go over it. We got handed a paper and that was it.
Okay.
In which class?
In Becky's on evening class. We got it, I think, like 2 weeks ago now.
Yeah. And you went, Dan, you went over ours in Jan's class.
Okay. Let's get the class code real quick.
So anyway, can you show them what the class code is?
I'm doing it right now.
I'm gonna have a heart attack.
Typed it in, so it's been typed in.
Was it typed in the chat?
Someone typed it in.
I have it if you want me to tell you, Karen.
Okay, it's typed in the chat. You guys get it from the chat and get into it right now.
I guess my point is when in class we ask if everybody's on, that's the time to raise your hand and say, I'm not there yet. Can you help me get on? That's a safe area. So that's the time to be asking, not 2 or 3 weeks down the road when you should have been doing assignments already. I'm not scolding anybody. This is very general. I'm not getting on anybody in particular. I just want everybody to know. I don't get frustrated like this very often, but this is very frustrating because over the last 2 weeks, I went into a class the other day and I tried to get them online to do something. I was going to show them something, and there were 3 people that hadn't accessed it at all yet. They hadn't even put in their access code to Vsim or DocuCare. So when my point is when we do this in class, when we're walking you through it in class, that's the time to raise your hand, not 2 or 3 weeks down when you've wasted 2 weeks of time that you could have been playing around with the stuff and all that. So
I think that's the point, is they have not done this in class, in Becky's class.
Been asking about it in class, but Becky says next week, and we'll do next week.
I spent an hour and a half in both evening classes trying to make sure everybody was on, and then Karen went in a week later and went over all of it again. So if we made a mistake, be sure to jump on us and let us know what we did wrong. Okay?
Nay.
We need to be held accountable too. So if we messed up somehow there, in
You guys can hold
communication, please share that with us.
Okay, let's move forward. So
Can
you
I
guys,
say one thing? Can I ask one question too? So I was really thrown in DOCUCARE over Yoder's date of birth, and I kept trying to find a place to change the date of birth. That threw me for a minute. And then I realized just skip it and let it go.
Why do you need to change the date of birth?
Because it's wrong compared to the other system.
And each person has a different date of birth because mine says it's like February 6th, 40.
Yeah, mine's different too. Every time I went to go like back into it, the date of birth would change.
so here's your patient info tab.
But you can't change anything.
Here's the demographics. And you cannot change anything.
Right.
Unless, let's see, current visit. Let's see. Let's just go through it real quick.
Sorry.
So real
No
quick,
worries.
Ray kind of changes info.
Say it again.
No, I'm just asking why is she trying to change the info?
It didn't, the patient did not match what I had. I had May 3rd, and this shows 4/29 in here.
I think that's okay. As long as it's Yoder, yeah, I think it's okay if the birth date keeps changing. Just as long as you have the information, like he's diabetic and your assessments that you do. It's the same patient. I think I don't know why it does that,
but good eye, Deborah. Good eye.
Yeah, good double checking. Yes.
Good eye. And we should throw that back to the people at Lippincott there or at Walters Kluwer.
Yeah, consistency.
That's right. Not the same guy. Okay. So where did we start? Instructions are, those of you, did you get the class code and get on?
No.
I'm hearing background noises, but I don't know if that's real people. I mean, obviously it's real. Those of you who weren't in the class, did you grab the class code and get on yet onto DOCUCARE?
I'm not able to yet.
Okay. So you're not able to try it? Is that what you're saying?
No, it keeps saying that it's not, that there's an error with it.
So if there's a 0, if there's an O, it's probably a 0. I don't know.
Okay, I went to 0 first. So should I try O?
No. Let's see. I can't see the chat because I'm screen sharing. So I believe all of them are 0s. I don't believe there are any O's.
Yeah, that's what
Looks like you have a black.
Are you looking for the class code or the access code?
The class code.
Yeah, that's probably fine.
What, do you have the access code again?
I want my water.
Katie, the access code is on that sheet. Everybody's access code is different. The one we gave you in the chat is just for the class code.
Okay.
Everyone's access code is a different code.
What are you going to
If you need to, you can talk to Janine at school to get that information.
Also,
okay, thank you.
When you look at your content, does it have Vsim and DOCUCARE in your content?
We're gonna stop at a smoke shop and get back some rolling papers.
Can you guys, whoever's talking, can you mute your mic?
Bombs proved last night there.
Hello, I'm not sure who that is. Is it Katie? Are
Yeah.
you?
It just shows Vsim.
It
And
just-
I need to find that paper with the access code because I think that's what I was doing. I was putting in the wrong.
Okay, so when you get your paper, you can just call Deneen today and she can give you the number. You're just going to hit this right here and put add a new title.
Okay.
And then once you get that in, then you can enter that class code, and because basically your access code will get you the book or whatever, and then your class code will get you in the class. Okay?
Okay, thank you.
You're welcome. All right, so let's move forward on. And also, it also has learning tips here, just so you know. You've got learning tips. up somewhere. I'm gonna let that go. Obviously, that didn't work out as well as I'd hoped either. So there's your instructions. So you know that you don't have to put everything in everywhere, right? Do you have to enter a new order? If so, you would do it here. Do you have to give medications? If so, you would do it here.
So for example, like if you go to orders, it says like dressing application and insulins for me. And then we'd add it because the ceftazidime is one that we gave. So, right?
Yes, you're correct. Not there. Not, you don't add it into the MAR. You add it into orders. You are correct.
Oh, yeah. Okay. And they give us those two just because they want to help us out, or like?
Probably in there from an earlier time.
Okay. Sounds good.
But I don't know so you would add a new medication order. It would be from the pharmacy. You'd choose your provider. On the date, and remember, date and time is always the day and time of the simulation, not your day and time. Is that correct, everyone? Or does it matter in document?
I think it always defaults to the day.
Well, this is today.
Right.
Okay.
So I think that will be the default day.
And is this a scheduled order, continuous infusion, or a PRN? Interesting. I don't think I've seen that before.
Can't read. What does that say next to it?
Browse by category or create your own order. Wonder what that looks like. Create your own name, URL. Okay, it's just talking about source for, oh, sorry. Search. Okay, there we go. So if you're searching for a medication, like sodium chlor, can I spell? I can today, maybe. Then you can pick your medication. All right, so I picked that. Can we move the page? And then you would finish your route, your frequency. Looks like it's a stat order. Standard protocol notes. We don't have any of that. And then you save that medication. Save failed. Please correct all your errors because there must be about 2 billion. Oh, provider. I don't know who the provider was.
Pick one, anyone.
There we go.
The other one was a nurse, so probably from the doctor.
Probably. Save failed to correct all your stinking errors. Try scheduled order. Scheduled order. I'm so good at this. I'm so glad Dan chose me. All right. Save failed. Dosage. 5. See, this is called Baptist 5,900 units. ml. Will it let me do that? Oh, it will. I feel like this is going to work. Oh, look at that.
Sweet success.
There we go. I think everyone's fallen asleep. Okay.
Karen, I have a quick question about Russell. I don't think we actually gave medication to him.
We haven't done. I haven't done Russell yet. I'm just doing documents.
Okay.
Yeah, I'm just in a student view of DOCUCARE to run through DOCUCARE. So patient info gives you his demographics here or current visit. So you can run through patient info if you need it. But again, it tells you what to document. So we're going to document the head to toe, right? So assessment, integument. Which one are you going to do here? So that was on 10/18. Do we need to reassess? Is this what we're going to find? No signs or symptoms of infection?
We have to reassess.
Thank you, Alvin.
Mhm.
So we're going to reassess. Which toe was it?
Right big toe.
Right big toe. Which toe reference? What are we going to put here? Wait a minute. Where's our... It gave us a reference, but somebody help me out here. Foot right, entire toe right. Oh, it already says it. Okay. Wow, Karen. What are we going to put here?
Erythema.
What else?
Cool.
Cool? You think it's cool?
I put and did tender and warm to touch.
Tender and warm. One-handed typing. I love it. All right. So length, did you get to measure it?
It's 1 inch.
Let's go positive. By what?
It just said 1 inch length wound.
It didn't say width.
No.
Had no depth. Okay. And then you would describe it. What are some of the descriptors you're going to put in there?
It had a foul odor, and then it had white along the edges, I believe.
So macerated?
Yes.
And they had an opaque discharge.
Oh. I can do it. Macerated edges. Okay, there we go. Oh, oops. Dressing and wound care. What do we use?
Sterile saline.
So we're, okay. So what are you going to put here?
Moist saline dressing.
Sterile. And moist to dry?
Yeah.
Gauze? Did you use calcium alginate? Did you use any of that?
Yes, it was on the orders. The alginate was on the orders. Karen, gauze is also AU.
Thank you.
You're
I
welcome.
go to Gaza. Okay. We have another spelling freak. I love it.
Yes.
She can join our club.
That's right.
All right. All righty. Anything else that we're going to put in here? Any other notes that you wanted to do?
Would you put about the dressing being soiled with exudate? Would you put that on the focus notes when removing the dirty dressing? Just so you could track it if it was.
I'm removing patient dirty dressing. What would you want me to put here?
Soiled with or fully soiled, depending on how much of the amount of exudate was present on the dirty dressing, so that you could track how the wound was healing based off of the dirty dressings, depending on how frequent the changes were.
Fully soiled with exudate. Okay, was it serosang and opaque, just like before? Yes?
Mm-hmm.
All right. Let's just go ahead and save that. What else are we going to do? So now we've assessed him. So you guys can see how we're doing this. Does this make sense to everyone? So we've documented our head to toe or our wound assessment. Which one?
Wound assessment?
Yep, we've documented wound assessment.
But since the wound was technically the only thing found on the head to toe, would that also count as the head to toe assessment?
It's a good question. I question that also. So you probably would start with that.
Okay.
As long as it's all documented, because your head to toe is in integument, we don't have any other wound. It's integument, so peri-wound, all that is under your integument. So document or assessment findings related to his delirium. Where is that going to go?
Mental health.
Mental health. So you're going to do your CAM assessment here. Tool used would be your CAM, right? Your score interpretation. I'm not seeing the CAM assessment, but I haven't been through this part of it all the way.
Under mental health.
It is, we are under mental health. Hey Mason, where is that? CAM's assessment, communication, coupling, true. Treatment, mental status. Oh, it's the thing you did before. You're just documenting it. Come on, Karen, get with the program. Cognitive impairment screening, tool used, right, would be your CAM. And your score was a 3, is that right? Oh, that doesn't work. And was he appropriate?
Yeah.
He was appropriate. All right. So additional notes to support appropriate. What would you put into supporting that appropriate behavior?
He was calm.
A note about documentation. And you might document here too. Also, patient stated, hey, Judy, can you help me out here? When asked about his date of birth, right? So you would put that in parentheses. Okay, so now you see how we're taking care of all this, correct? People can see what we're supposed to document, where we can document it. Yes?
Yeah.
Yeah.
Yep.
Any questions here?
No, not anymore.
Okay.
Thank you.
Yeah, absolutely. Document the patient and family education. So it would be under teaching, record new patient teaching. So one of the things about nursing notes is you never want to put I, and you don't want to write a book. You want to make it short and sweet. Just think about you're coming on shift. You have 14 patients. You have a 5-minute handoff report, and you have to go in and look at the nursing notes of each patient to make sure you're doing the most important and emergent things for this patient. Do you want to read a novel about all the great things that this patient was normal about, or do you want to read all of this, the simple instructions of how someone did a dressing change?
No.
No, you want it straight to the point.
You do want straight to the point, Alvin. You want it bullet pointed. You want to leave no questions unanswered as far as, I mean, every nurse knows how to do the dressing or they wouldn't be a nurse. Every nurse knows how to give the insulin. So you would just document place, etc. But you don't want to give any details. If you were going to talk about yourself, you would always put this RN. This RN administered if you had to talk about yourself. There really isn't a lot of times when you have to talk, and you would never, ever, ever throw anybody else under the bus, like saying previous RNs did not change dressing, but documented they changed dressing. This is not the place to do that. This would be a discussion between you and your manager or something, but this is, all of this electronic health record is discoverable evidence. And if you throw your facility under the bus, then they will throw you under the bus. So please don't. Everything would be succinct, straight to the point about things that needed to be documented. Nothing emotional ever that comes from you. That makes sense?
Yes.
I think everyone just except Alvin and Reed.
Yes.
Any questions here in DocuCare?
No, got it.
Not anymore. Thank you for that.
Yeah.
Yeah.
That's what I was very frustrated with because I didn't know how to navigate, but now I do.
Right.
Good.
Me too.
Good, good, good. And remember, you got to take notes. You definitely have to take notes.
That was one thing I wasn't doing the first time around, was taking a lot of notes.
Yeah, so you'll have to take notes whenever you do your Vsim so you know what you can document.
Yeah, I thought you were going to be able to access that after you were done, but I was wrong.
And that's what's really interesting, is because they did tell us that you can print that report and it will give you the blood pressures, the CBGs. So I told her the other day that is absolutely false. She's looking into that.
Yeah, because it was very confusing because I didn't write every single thing down, and I got in DocuCare and didn't know half of it.
Oh, good. Look, Lori, I used all of your time. I'm sorry.
Can I ask a quick question or a clarification?
Anytime.
Okay, so in order as to what we're supposed to do, so we're supposed to do the
Oh, hi.
Oh. So Vsim, let's check our score, get above 85. If we don't get above 85, do the remediation.
Hey, Emily, can you mute your microphone for me, sweetie?
Oh, yeah.
So get 85, but we can keep retaking it until we get 100. For example, say we just want to keep doing it right. And then if we get that 100 score, we do not need to do remediation for the other ones that we've got.
Only below 85.
Sounds good. And then do your DocuCare and then the packet that Sue sent us.
Yeah, those 4 pages. Yep.
Okay. All right. I think I got it.
I think you guys are going to do amazing. And when you get to second term, I'll expect miracles. So, you know.
So I found, particularly when I had gone through it, if I wrote down the order of things the way they wanted them, it was really helpful to me the next time I went in. So if I looked to see what did I put in the wrong place, what did I not do fast enough, then when I went through it again, I could sort of follow a pattern the way they wanted me to.
And if you do the pre-reading, I can't stress this enough.
Right.
If you do the pre-reading and you get a sense, even if you don't understand the pre-reading, and just then relax. Remember, your brain's got to put that all in order. It's all language that you don't know yet. Then go do something fun. I don't know, throw water balloons at your neighbor, anything fun that might get you to relax and laugh. Let your brain put that in order. Then the next time you read it, you'll be able to pick out little things in that to be able to put in that clinical replacement packet. Because that's where you're going to get your information for a lot of that stuff. The clinical replacement packet I now call a CRP.
That's good. Not CPR.
Not CPR.
CPR.
And I want to tell everyone here, if you're sitting there thinking, I thought I was overwhelmed before, now I'm just going to go off screen and cry because I'm so overwhelmed, I want you to know that all 4 of us instructors are here for you. We don't want you to sit there and cry. We want you to call us. We want you to Zoom with us. And we want to know what your questions are. Put them in an email or call Dan now that everyone has his number. And and use your resources. When you become a nurse, if you don't find your resources, if you don't find your catheter queen and you don't find your phlebotomist and you don't find all these people that you need for resource, hey, I'll trade you the catheter for this IV. Will you do that for me? Then you're out there on your own. But
all nurses survive on coffee. Take them out for a coffee. Say you'll give them 50
so many times. I'll do this for you if you do this for me. No. Okay. Well, I will bring you coffee or a Red Bull. Got a deal. Every time.
Just carry around a bunch of Starbucks and Dutch Brother coffee.
That's right.
Learn one another's strengths too. You know, there's some people who don't mind doing things that I would put down an NG tube or stick a lavage tube down anyone before I'd wash out an ear. You know, it's like, know what your strengths are. So I just trade. Hey, would you go do that? And I'll take the next NG tube, you know.
And that's exactly right, Lori. That's such an important point. Every one of you is born with strengths and with gifts, and that you may not think you have any gifts or any strengths. That's baloney. Ask your friends, they'll tell you. Focus on your strengths and your gifts and use them. Don't be afraid to use them. Don't be afraid to develop them. And then if you want another gift or you want another strength, don't be afraid to use your resources to gain that gift or that strength. That's super important for your development as a nurse and a human being. We all have gifts and strengths. So find yours, write it down, use it.
You know, Karen, I just asked my friend right here what my strength was, and she basically just told me my attitude problem.
It was not bad. I said you are a hard ass for people that you love. It's my class. Sorry. Yeah. What? I did not say you had an attitude.
Hey, sometimes you can work that attitude.
That's right.
Sometimes benefit.
Especially if worked really well with combative patients in the past.
That's right.
Try to make friends, not enemies, and think before you speak. Don't let your emotions get you. But hey, in nursing, I know it's gonna happen.
Yeah, right. The emotional piece, if you can hold your tongue before you go there, it always turns out a little better. Never send an angry email. Remember, you can't emote in an email. All right, are we good to go, Mr. Dan, Miss Lori?
Unless there is any other questions out there. So although we should probably try to figure out next week what is going to be the best time to try to meet next Thursday for our next Zoom then. Do we want to do earlier than 9, like 8:30 or 8, or do we want to stick with 9?
Getting out,
Teresa?
Yeah, getting out at 2 or 3 works for me. I know some people need to get out earlier than that though.
I have kids to go pick up, so can I just like text the group message and I'll find out then?
That sounds fair.
Okay.
We also we have the option of having another sim if you want to do that for your time next week also. So if you prefer to just work on Millie Larson next week, we can add that in as your time and you wouldn't have to have a Zoom.
But you can't do both though, huh?
Well, you don't need both.
You don't need the both, huh? Okay.
Well,
you do need the both because
we've got other homework that's already assigned
No.
that has to be covered for week 10. So
are we assuming that we're not going to be coming to the school next week then?
that's what we're assuming at this point. It sounds like they're not planning on having us back. So
okay.
So we can continue what we're doing, just do another Zoom next week and find
a Zoom.
Okay,
Same time, same place.
Yeah.
We can just cover the topics we would have covered in class on the Zoom, so.
Okay.
Okay, so do you just want to do one Zoom and have some homework? Do you want to do 2 Zooms again?
I'm okay with Zoom.
I'm
I
okay
can
with
work
them
out
as
work.
well.
Two Zooms still?
That was fine. An hour break in
Then
between
we can
those
have like a
was
lunch
cool.
break in between.
Yeah.
An evening one because I actually work in the mornings.
That's what
Dan,
this
what do
was.
you
This
think
one.
there? Because I understand that a lot of you are evening people and you're the day people. So, which is why we are recording these, is so that the night people do have the option of watching them and just taking notes. Did we lose Dan somewhere?
I'm here. I didn't get the question.
Whether to have an evening session or to just do the sessions we're currently having.
I can do an evening session if you want. Just let me know what you want. I get paid by the hour, so let me know.
You guys are
not really. You just get paid by the week.
I mean,
no, I don't mind. I'm here stuck at home, so yeah, let me know, and I can. I can't do it tonight, but any other night this week or whenever you need one, just let me know, and I'll make sure that I'm there to cover it, whatever you need.
Do you want us to fill out one of those virtual timesheets that you send out in week 1?
Just add them into the previous ones, like week 8. You can add it into week 8.
Along with reading, Jessica.
What was that, Gabrielle?
Along with your chapter that she assigned to.
Oh, just the timesheet then?
Yeah, you can just write them in. Since you already have a timesheet for week 8, you can just write them in.
So can I get clarification real quick? So I know the Vsim is due next week. What about the assignment that you gave us? Is that due on Sunday of this week, or is it due next week?
You know, we just made everything for week 8 due at the same time. So the
Same
only
time,
other
okay.
thing, yeah, because we had the Vsim this week along with just your lab stuff. So there
Okay,
wasn't that
I was
much.
just wondering.
So now we've thrown in a chapter, and yeah, so they'll all be due at the same time. It's easier
Okay,
that way.
that makes sense.
And I have a question.
But just remember, you have week 9 assignments that will also be due at
Yeah,
the
I
same
know.
time.
Yeah. So we might as well start on it now then. Okay.
I know Elise has a question also.
I have a question. So I know you guys gave us like the questions about like how you guys are going to know if we're here, like about the where would you find the resources to fill out the form thing. So
those are people who are viewing this instead of attending this.
Oh, okay. Perfect.
Yeah. Since you guys are here, you're getting your credit already.
When will the soonest we will find out like what's going on next week? Because I need to let my job know so I can take time off of work, or
Also, I'd kind of like to get a decision if we could. Do you want to do maybe 8:30 to 11:30 in the morning and then just do a couple hours in the afternoon?
that'd be great.
12:30 to
Yes, that'd be
3, would that work for you guys?
Yes.
Yeah, some people will be at school
Okay.
anyway, so I mean, it doesn't matter
Okay.
to me.
So we'll say 8:30 to 11:30.
Okay.
And then we'll do
Do
then
we want to plan on one for evenings?
30 to 2:30.
And then you want to do 2 to 4 or 2 to 6 or whatever.
So when you're talking evenings, what times are you thinking?
2 o'clock. You can start evenings at 2 o'clock.
Well, if we're going to do a 12:30 to 2:30 already.
Oh, I see what you're saying.
Yeah, but does evening shift need like a 2 to 5 or something like that? Would that help?
That only gives them 3 hours, but they can watch the other one for the
Yeah.
other 3 hours.
Well, we can
Yeah.
go as long as they want. If
One's a good one. Please ask the question and maybe watch the other one.
So 8:30 to 11:30 and then 12:30 to 2:30. That's our
So
our goal right now.
Okay. Sounds good to me.
does that work
I mean,
okay for night shift?
No.
I mean, no, but I have to take the day off, so it doesn't matter.
What does night shift need? What hours?
2 and beyond.
I'm fine with doing the morning shift.
So if you can't be on the time that we're on, you can always look at the video and document that time that way. So you can kind of choose when you want to watch it.
Okay, so we have a few that need the 2 o'clock one, 2
Yeah.
to whatever, but
2 to 8:30.
those are the open hours is what they're saying.
Okay. Yeah, so somebody they want to know what if they'd repeat the hours for next week for the Zoom meeting.
So right now we're doing 8:30 to 11:30 and 12:30 to 2:30.
Okay.
So if you're going to add an evening class, it would have to be after 2:30.
And it will still be the same Zoom information, correct?
Well,
Yes.
the thing is we don't want to repeat the same Zoom information if you can just view it. I think that's kind of the consensus of the online aspect of this.
No, I mean like to get onto the next Zoom.
So I'm assuming
Oh,
out invitation again.
It'll be the same invitation number.
Okay, just the login information is going to be the same. Perfect.
Yeah, just same code, everything.
So was a decision made for nights? I'm sorry, I was typing.
I didn't hear anything.
I think they would watch the recording and then some of them were okay with the AM. They didn't say anything else though.
Yeah.
So Elise sounds like Elise. How many night people do we have right now
I think there's like 19 of us total.
for the night?
Between both Becky and Jan's class, I believe there's 19 of us.
Okay. Okay.
And that's an option too, is that we can talk to them and see if they would be able to set up a Zoom for you guys.
That's true. That's true.
Because Jan will probably be feeling better by then. She's feeling pretty lousy right now, but.
So you guys will talk to Becky and that. And
does Becky or Jan know how to do Zoom?
We'll figure it out.
Don't know, but we can certainly ask them.
If not, we can help them. I can set up the meeting for them if they need me to.
That's true.
Okay, I'm gonna leave. Bye guys.
All right. Thanks everybody.
I have to leave as well, so.
And if anybody has questions and they didn't want to ask them in front of the big crowd, just stay on
Thank you.
and I'll answer.
And quit being so bashful. You need to be able to, if you're going to be a leader and an RN and an LPN, you need to be able to speak up. So that's my smack for today. Take it with a lifesaver, a donut, or something sweet.
Okay, you can stop your recording.
Maliciously.
You can stop your recording.
Okay.